Okay, you can continue. Thank you.
Okay, thank you. Good evening once more, everybody. Thank you so much for joining us on this webinar. This is our second webinar for 2026, part of the onboarding program. A joy and a privilege that we have Dr. Mandondo today, who will be talking us through bleeding issues, face these kinds of challenges, and it would be best to be capacitated on how to deal with uterine bleeding in the context of a primary healthcare setting. Dr. Mandondo is a gynecologist specialist in East London. I'm sure most of you are familiar with her care and onboarding presentations. If you've looked at our YouTube channels, you would have seen a number of videos where she's talking us through a number of obstetric emergencies, etc. She is part of the DCST team, and I am also privileged to have worked under her care and leadership in Cecilia Makiwane and Frey Hospital. That's also where I got my diploma under her mentorship. So I am very happy to present her to you this evening, and I'm hoping that we won't have any glitches in technology. I do want to emphasize that we have a poll that's going to appear at the end of the webinar. So if you are interested in CPD points, you have to make sure that you are a RUDASA member. Becoming a RUDASA member is free of charge. Once you've become a member, you can just fill in the poll, and then you will have your CPD points accredited to you. We are still in the process of finding out whether these CPD points will be accredited after each webinar or at the end of the whole onboarding program. So you will just have to look out for that update. Dr. Mandondo, I don't know if you are ready on your side, but I think we are all anticipating to hear from you this evening.
All right. Thank you very much, Asafia.
Thank
It looks like the slides don't move. If I think we'll have to do like this now, because if I put them on slideshow, I don't know if I should try again. Is it okay? Can you see two slides? Is it not on slideshow on your side?
I can see slides, but it's not on presentation mode, but we can definitely read what is written.
Okay.
Yeah,
all
now
right.
it's on.
So, colleagues, I'm going to take you through. I was asked to talk about managing assessment and management of abnormal bleeding in a non-pregnant patient. So basically, I'm going to introduce you to the new figure terminology, which is actually going to assist you in terms of managing the patient and in terms of having a good differential. Just as a recap, we need to talk to the menstrual cycle because everything is dependent on the menstrual cycle. So we know that day 0 to day 4 of the menstrual cycle is actually called the follicular phase. We've got a follicular phase and a luteal phase. So basically on the follicular phase, after that, you're then going to have a corpus luteum, which is going to form, which is regulated by specific pituitary hormones, which is the FSH, which then rises and peaks around the day 14. And when it does peak to the FSH and the LH, they peak around 14, which is actually the timing of ovulation. Then the egg is released, and once it's released, it will remain with the corpus luteum, which will then take over, will produce the progesterone, which is going to govern the menstrual cycle. So then we'll also have an endometrial phase of the cycle, which is initially quite proliferative, and later on, then it's what is called the secretory phase of the endometrium. So it's important to familiarize yourself with this because the drugs we're going to use are going to be dependent on that. So abnormal uterine bleeding, basically, they can be normal or abnormal. So in terms of normality, there's frequency, regularity, duration, and volume. So for most people, they've got a 24-day cycle up to a 38-day cycle. So what becomes abnormal if you do have periods less than 24 days, and then if you also have periods more than 48 days, and then also it becomes a problem when you have a primary or secondary amenorrhea. Okay, so we'll talk to those. That will be. Then in terms of regularity, right? So it depends on age. So your first phase, you've got menarche, and after that, from 18 to 15 years, the variation may be in 9 days, and between the reproductive years, 26 to 41, then the variation is 7. And then from 42 to 45, before you can start your menopause, the variation will be 9 days. The duration can start from 3 and it can go up to 8 days, which is seen as normal. But then if you have periods that last more than 8 days, that's much more abnormal. Then in terms of volume, right, they say that we're talking about 80 mils of loss per cycle. But also, then it's also there's a subjective assessment where there's actually blood loss that doesn't interfere with your lifestyle, with your mood, with your social and emotional well-being, or you can have menstrual bleeding, heavy menstrual bleeding, that can then be seen as abnormal. So we are worried about primary amenorrhea. So I'm just going to try to do it by ages. So when you have the primary amenorrhea, right? So it's a problem. So, and what are we going to call primary amenorrhea? So when you have primary amenorrhea, you expect endocrine issues. You know, you need to deal with that, and we'll look through how are you going to deal with those. So what do we call primary amenorrhea? It's when anyone hasn't had a period from the age of by 14 they should have periods and secondary sex characteristics. Then some of them will have secondary sex characteristics but no period by the age of 16. And then secondary could be due to many things. So this is the classification that we're going to talk about so that you can become, when you clock a patient, you can use this palm coin so that you can then think about the differentials and be able to say no, yes, no, yes, no, yes to palm coin to be able to figure out what is the problem. So I'm going to, so with primary amenorrhea, with the primary amenorrhea, or the first thing is that you worried about chromosomes. So basically in a PHC setting, you're going to say consider watchful waiting, or you have to perform other investigations. So you ask yourself, is the secondary sex characteristics? So if there is none, you measure the FSH and the LH, and then you look at if the FSH and LH are less than 5, then you can think it's hypogonadotrophic hypogonadism. But then the main thing is that you actually have to think about tenors. And when you have tenors, it's important that you don't go to do FSH will be high, LH will be high. So this will be available to you. And therefore, you must then think about two things. So you can see that there could be a premature ovarian failure, or the other thing would be tenors. So these are people without the secondary sex characteristics. Then you come to the person who has got, normal secondary sex characteristics. And the main thing there is that you've got Müllerian agenesis. And when you have Müllerian agenesis, the person has got tubes, but they don't, and they have ovaries, but they don't have a uterus. It's often not there. But their karyotype will actually be completely, you will have a 46XX with Müllerian agenesis, and androgen insensitivity is when you're going to have an AA46XY. Then you will have to think about outflow tract abnormalities if the uterus is there. So, I mean, sometimes some of these ladies, you don't believe they only come after the age of 20, and then you find that they've got Müllerian agenesis. So then, and voila, you've got a vagina. Because remember, with the Müllerian agenesis, you do have a blind vagina, but it's short. It's short and blind ending. It doesn't lead to a cervix, and it doesn't lead to a uterus. So the core skill for primary healthcare is really what I'm going to talk to at the end, really how to do the transvaginal scan to make sure that you can pick up on these things. And then when the uterus is present or normal, then it's an outflow tract, so which is likely to become an imperfect hymen or a transverse septum. So this is an example of when you have a hematocolpos, with a primary amenorrhea, the patient may look like they have an abdominal mass, but that is because of the imperfect hymen. So you can see that that's the uterus, that's the cervix, and in that vagina, you can see that mass that is filling up. So now, if the person has secondary amenorrhea, how are we going to approach this? Again, the drug, the blood test that you're going to do, it will be FSH or LH, and then you're going to do the TSH, and then you're going to do a progesterone challenge. So how do you do the progesterone challenge? So you're going to give Provera, and you can give her 10 milligrams of tablets, and then you see if she's going to have a withdrawal bleed. So if then she will have a withdrawal bleed, then you know that the problem was anovulation, and that will tend to be associated with FSH is normal, and then you'll have a high LH, and this is more common with PCOS that will be associated with weight and other abnormalities. Then you can have someone who's hypoestrogenic. Therefore, you will have the challenge will be fine. And then the problem there will be that there's an ovarian failure. So once you give the Provera, but there's still no bleeding, there could be an ovarian failure. Then the last one will be a compromised outflow tract, which is Asherman, and where the problem is in the endometrial lining. So you need to assess, you need to do a hysteroscopy actually to assess the lining of the uterus. So as I've been talking to you now, we're saying that, so if you've got irregular bleeding, so you see the association. So in the younger patients, PCOS is common, and then you must remember that you have to look at the breast to see if there's any hyperprolactinemia or there's galactorrhea. Then you, for the young, so I'm looking at the young patients, weight loss or weight gain. There could be heat, cold intolerance, or light thyroid, which means there could be thyroid disease. And then less common etiologies will be in the endometrium and in the uterus. And therefore, the most important thing would be to do the endometrial sampling. So when the patients are a little bit older, then you start getting other problems, which is now either polyps or endometritis, which is an inflammation, or there could be a problem with the Caesar scar, which is rare, as well as risk factors for uterine malignancy. And we know that the body mass index from 30, and as it increases, you're going to have unopposed estrogen, which is going to be lying in the fat, and this will make them prone to endometrial carcinoma. So we're very worried about a hypertensive diabetic that's obese. They in themselves will have a problem of the endometrium. So the main thing would be the evaluation would be endometrial sampling. Then you've got other problems, right? So this is much later on in life that you can then have a problem with the uterus itself. So the uterus may have fibroids, which is common, and many people wanted their fibroids operated on. Fibroids do not really mean that you are not going to have children. So we must really know that how to recognize on the pelvic ultrasound. There's also a saline infusion sonography where you just put water inside the endometrial cavity so that you can identify. We'll go into more details. And then dysmenorrhea will be associated because the uterus is big and boggy. Will be associated with adenomyosis, and then there'll be family history of bleeding disorders, and then the risk of malignancy is what I've talked about. So basically, the history, as I've said, you need to really go through like menstrual history and pattern, sexual history, then gynae or surgery, contraception, and then risk factors for hyperplasia and medical history. The basic exam is really to look at the BMI and look at thyroids and look at any evidence of hyperandrogenism, like excessive hirsutism, and there's this pheromone Galway to assess like if the person is extremely hirsute and the acanthosis. And then the pelvic floor examination is very important. Just look, but don't confuse with vaginal bleeding. Look for the urogenital and look in the rectum and look at look at the hemorrhoids as well, right? And then you will assess now basically how you feel the uterus and if you feel an adnexal mass and the baseline pregnancy test. So then the secondary will be going to more detail in terms of the bleeding history. And then the most important thing will be to look at contraceptive history, especially if the patient is on hormonal or IUCDs. So now, in order to be comprehensive in your assessment of these patients, we use this terminology called the PALM COAIM. So each of these stands for something, right? So whenever you assess a patient with bleeding, you're going to write this word PALM COAIM, and then you're going to ask yourself, P, what does P stand for? So P stands for, do you have abnormal bleeding due to the P? And this could be, is there any polyps? So it stands for polyps. So you look, when you examine the cervix and the vagina, transvaginal ultrasound, you're going to see if you can identify polyp. And then if there is a polyp, right, polyps tend to be more benign and they can be removed easily. And then the A means the adenomyosis. So when you do the ultrasound, you need to check, right, how thick is the uterine wall? So basically endometrial type glands and stroma, like they are within the myometrium. So that you've got this soft, boggy, big uterus, like, and therefore causes a hypertrophy. And then this association is not very is poorly understood, but you cannot really confirm this. This will be based on the clinical, so you can't have histology to confirm, but when you do transvaginal ultrasound, it's very important. Sorry. Then the next thing is the fibroids. Colleagues, the fibroids are a stress. I think in the primary healthcare setting, you must be able to to assess some fibroids and really decide what really needs to be managed. Because when you see a fibroid, it doesn't mean that they are symptomatic. So there could be fibroids could be submucous, right? So when it's there, it's in the cavity, it's pedunculated, and that may interfere with implantation in a pregnancy, like with pregnancy loss, or with early pregnancy losses or implantation when a person is infertile because of that. Then submucosal ones, then can be intramural or bigger. Then others, then you can see that you've got subserous fibroids. You can see here in this picture. I don't know if you can see it well. So we can see that where is most fibroids that you're going to identify on the ultrasound will be 2 and 3, which will really be on the intramural, 100% intramural. 2 will have any contact with the endometrium, and hence those are the ones that will be responsible for other problems. Then you have got subserosa, that's 6 and 7. And sometimes the subserregulars can be pendulated such that you can feel the mass on its own, and then you can actually get a hybrid. So a number of fibroids that are actually hybrid, and they are all over. So this is the classification. So when you say you have L, you have to say, look, is the same mucosal, is the same endometrium, and intramural, is it a subserolazal fibroids? So if you can identify that. So that's what the saline sonography also helps you to be able to recognize this. Then the M is the malignancy, right? So as we know that inside the uterus you can have the endometrial thickness. So we're going to go through the ultrasound features of this, and we're going to discuss the management when you think malignancy is possible. But the problem is that with endometrial cancer, the treatment is very easily curable with simple surgery that can be done at a lower level, and you find the 5-year survival can be about 85% in most white people. For us, maybe less because it may be picked up early because people are so embarrassed about talking about this postmenopausal bleeding, and yet it's something that could be cured easier and cheaper than the others. Now, then we've done PALM. PALM is talking about the structural abnormalities. And then we've got the coin. So the thing is, we've got patients who have got coagulopathy. So a lot of medical patients will have a coagulopathy, ITP. You need to do the platelet count, and you've got those protein C, protein S, all of those coagulopathic conditions. So you need to do the blood test to confirm it. And then O, which is the very, very common one, which will be the ovulatory dysfunction. So this patient shouldn't be on any medication, like I told you that if the patients are on hormones, then they could be causing the bleeding. But if the patient, right, was not ovulating or has frequent ovulation. Okay, so what needs to be done here when you have these patients with the ovulatory dysfunction? You can see in this picture, this is what we call polycystic ovary, but you can have polycystic ovary without the polycystic ovarian syndrome, which will now be associated with hirsutism. So these patients may have the ovarian features, but they will have no weight abnormalities, no acanthosis, and no hirsutism. And then what's important when you then assess the ovary, it's very important that you can have a simple cyst, and you can see a simple cyst could be less than between 3 and 5 centimeters, and this could be a corpus luteal cyst if someone is pregnant. And please, colleagues, when you tell patients about this, please reassure them that it's normal. They've just ovulated and hence they've got a cyst. And cysts with less than need reassurance. Patients don't need to be referred to gynae and travel all these distances for evaluation of a cyst. So if the cyst is between 5 to 7, they should undergo a yearly sonographic evaluation. And giving the patients any combined oral contraceptive will assist these patients will cause the cycles to be anovulatory, and therefore, like any combined oral contraceptive will shrink the cyst. But then after postmenopause, you shouldn't be expecting to have simple cysts, so your threshold must be higher for risk of cancer. The E will be endometrial function. So we have a lot of STIs, and sometimes you can then you can have a chronic endometritis, and sometimes you actually sample, you do an endometrial sample. You used to call it but you can do a PPL. But you can be very surprised that you can actually find chlamydia, but you can actually find in the endometrium, you can actually find TB of the endometrial cavity. I think I recently saw a patient and I was very surprised. And another one where I looked at the cervix and I thought there was cervical pathology and the histology came back with TB. So we must remember that it can happen. And then iatrogenic. So the eye will be iatrogenic, which is now we're giving the patient warfarin and those drugs, and that will cause bleeding irregularities, and that is the eye. So now if you have to choose a treatment, are you still there?
Yes, we are.
Oh, okay.
Yeah.
All right. Okay. So now, if you choose a treatment, we also know that it depends on the severity, the associated symptoms, the contraceptive needs and plans, medical comorbidities. Then remember that most of our treatments have hormones. So we've got the breast cancer risk, and we've also got the VTE risk. So you need to just double check in terms of if those things, do a full examination of the patient to ensure that the breasts are examined, and the patients may have preferences. So if you want an article to review, this is a very good article to review. And therefore, how are you going to manage these patients on medical management? So one, you're going to say, you have heavy menstrual bleeding. Are you looking for to conceive or not? So if the patient said, look, I don't want anything hormonal, I want to conceive, or I don't want anything hormonal because of religious or other practices, then fine. But if the patient is looking to conceive, then you are stuck with tranexamic acid and NSAIDs, right? So mefenamic acid is a good option. You can look at other options as well. Okay, so now if the person is not seeking a pregnancy, right? So you can actually look at, if you want to look at the uterus, you can do intrauterine insemination. You can do the ultrasound with saline. So now you have to ask them, are they happy with the Mirena levonorgestrel, which is an intrauterine system. It works very well, and those people are happy. They can keep it for 7 years to reduce the bleeding, and it will actually reduce even your cancer and endometrial risk, partly because of the fact that there's the progesterone there that reduces, especially in someone who's obese, it will reduce the stimulation of the endometrium. So if they do not like any intrauterine system, they want something oral, and they feel much happier with that, then your choices would be, if they don't want drug or hormones, they will go for tranexamic acid and NSAID. And then the last ones would be to go for CHCs, combined oral contraceptive vaginal rings, and then they can also go for oral progesterone. So it's very important that you think about this algorithm. So when you have this bleeding, right? So I'm going to go through these drugs. So the thing is, if a person, this is the people who are not on hormones, right? They are not on contraception. So for them, the most important things we start with overall. When we say EE 50 micrograms, we're talking about overall with levonorgestrel. But it mustn't be used for 7 days and then you stop. You must do it for 3 months or after 3 months. Then progesterone, you can use cyclical progesterone, 10 milligrams. I think it's available in state. Then the third choice will be progesterone only pills. And then the NSAID will be Brufen 400 to 800 2 times a day. And then mefenamic acid actually works with the pain and actually reduces. And then tranexamic acid, as we've described it. This was in this paper by Manso in contraception. So what about the Mirena? So we do have Mirena in state, colleagues, and we're really happy for you to use it for abnormal bleeding. And it has got benefits, really. So it does improve iron, improve ferritin levels. Continuation is good. After a year, people can use it, and the mean blood loss can actually be significantly reduced. Maybe heavy the first month you're using it, but as months go on, it will actually be reduced significantly up to 4 years. And then mean blood loss, with oral contraceptives, really the continuation rates are less people, but we said we are worried about the breasts, right, and people with VTE. So you'll avoid it in those patients, and in people with a strong family history of breast cancer can also avoid it. So this will be used especially for fibroids, for endometrial problems, and for the adenomyosis. Then progestogens, all right, progestogens data is very limited. People don't use it. They tend to discontinue them. But it's useful in people who are really where you are avoiding to use estrogen. Now, non-steroidals, I've already talked about it. Mefenamic acid works better if you can access that, but you can use brufen or naproxen. Then, and this works, but then the problem is the nausea and the vomiting and the headaches. Then tranexamic acid, really, the mid blood loss will be reduced by 34 to 56%. And this is very important for people who have got the coagulopathies and endometrial problems, and and then there's good benefit for this, but it shouldn't be used long term. So initially you will do it for the first cycle, and then after a month you discontinue it if there is an issue and then there's a problem with the VTA. Now, surgical treatment. So in our setting, in states, other people will say, oh, I'm tired of the loop, I want a hysterectomy, but people must understand about the pelvic floor, the urinary abnormalities, the pelvic, the sepsis, anesthetic, and because most of these patients actually have got poor surgical morbidity anyway, so really it's better for you to attempt to use surgical methods for these patients. But then when this thing fails, about 46% will actually go for hysterectomy, but conservative management is much more effective and has very, very high rates of, so which is this in your primary healthcare setting, you should all be able to insert a Mirena or learn how to and be able to do that with your scan. And then if there's no desire for fertility, yes, people can go for surgical treatment. Now let's go to this endometrial sampling and the cancer risk. Colleagues, cancer, after cervical cancer, endometrial cancer is quite common, and in our setting, we've got about 15% of our patients presenting with after cervical cancer having endometrial cancer. So, at the age of 45 to menopause, patients will have very irregular bleeding. This is called the perimenopausal phase. And it's actually very important that as a person approaches menopause and gets to menopause, that they need an assessment of the endometrial, of their endometrial. They must have, after you finish and you've got your last periods 1 year after that, you want to know what's happening. You want to know, do you have ovarian problems? What is your endometrial thickness? What is the size of your uterus? All of those things are very important. So we need to really, before patients have come with complications, I suggest everyone who's menopausal go and see a gynae, just for a general gynae exams in addition to your pap smears. Then patients who are younger than 45 years, right? What is the benefit to actually doing the endometrial thickness? No, really. Not really doing endometrial thickness, but if they have abnormalities in this bleeding, you can actually consider sampling them. Okay, so why are you doing this sampling? So we don't want you to sample too many people. Said in obese patients, any abnormal bleeding in obese patients, BMIs of more than 30. In non-obese patients, abnormal uterine bleeding that is persistent and occurs in the setting of one of the following: chronic ovulatory dysfunction, they are exposed to unopposed estrogen by progesterone, they failed medical therapy with bleeding, or they have a risk of endometrial cancer. Now, it is actually important. Now, what we are seeing more of is that some of these patients, even though they are perimenopausal, they tend to be given oral contraceptives. Colleagues, we cannot be given oral contraceptives oral to patients who are perimenopausal or postmenopausal, because now this stimulates, and therefore when we do this, you find that they will say that no, man, this patient does look like it's actual estrogen exposure that is contributing. Okay, so what do we do if we are worried about these patients? So many years we did the DNC, right? So everyone was admitted at the DNC, and which is not so nice, and there's a small risk of stenosis and perforation. Now we are really doing office sampling. So each and every one of your hospital, please go and check if you've got PPLs, because the PPL is just like a straw. You get it in and it will give you tissue and will give you a good endometrial sample without any need for dilatation, because they're very, very thin. Then thinner sonography, I think in district hospitals don't do it, but it's basically inserting a catheter into the uterus, and then if you do that, you'll be to identify the polyps on the ultrasound because it creates kind of a contrast, you know. And if you've got polyps, you can actually do these polyps. So this is a technique that you can read about, which is the saline infusion sonograph, which can be accessible in the district hospital, but in the tertiary, they tend to go with hysteroscopy. Now, coming to something very important, transvaginal ultrasound, colleagues. All of you, don't start with, you can, when you're going to scan a patient, you start abdominally so that you can see if there's something big, right? But our general gynae examination means that we're doing transvaginal ultrasound. 2, patients, when you're gonna do a transvaginal ultrasound, you must make sure they go and pee. And therefore, after the bladder is not too full, you know, because if the bladder is very full, it pushes the uterus out of sight, and therefore you can't see much. Patient is uncomfortable. You don't identify the pathology you want. 3, you need to put a wedge under the patient. So instead of keep on telling the patient they must lift up their bum, they must lift up the bum, you want to take a pillow and put it and wedge it, put it under the bum of the patient so that you are able to move the probe up and down. In terms of doing this, really, you initiate, you go in and you must look at the probe marker. It must be at 12 o'clock. And then when you are there, you will see the fundus, isthmus, and the cervix. And then you then the uterine length and the height. And then after you've done that, right, you must be able to move the probe up and down, and then you can go left or right. And then after that, you are actually going to see, this is what you will see. That's a fundus there, so that's the mid-sagittal plane. And then you can see an endometrial, the cervix and the endometrial line. You see an isthmus and you see the fundus. Now, this is, sorry, I don't have a pointer, but this is where you measure from the fundus to the edge of the cervix. You measure a length, and what you see here is the height. You will miss any ovarian pathology, colleagues, if you stay on this plane. So once you are done with this plane, you need to take the probe. Now, if the probe marker was at 12, you need to turn it 90 degrees. And when you've turned it 90 degrees, this is the view that you seek to get. And this is what will give you the width, right? So you can see that it will like your lips and the mouth, and therefore this will actually give you now this angle. It will give you a width. Now, when you have done that, now you can then move your probe. So if you take your probe, you take it towards the thigh of the patient now. Then you'll be seeing, if it's on the left thigh, you'll be seeing the opposite side of the patient. So on the right, you'll see the other patient. So this is how you're going to identify anything next. And then these are some measurements that you expect to get. So most patients, like, it's 7, right? So that's why if you put in a loop, you measure normally the length of the uterus is about 7 to 8, you know, and when then you approach menopause, it goes to 6.7. When you are menopausal, then the cervix will stenose, and the uterus will get smaller, go to 5. So most of the time you'll get 7, 4/3, which is by the width by height. But this is, for example, just not an estimation of what you would get. You must be very careful, colleagues. Once you put the transvaginal ultrasound, if you see free fluid on this, go back and check about your pregnancy. Even if you don't see anything on the adnexa, where we've highlighted the free fluid, then you must say, let's go and do a pregnancy test here. Maybe you have missed it, you didn't look for it. And then endometrial thickness, I will start by showing this. So it changes as time goes. So basically depends on the menstrual. So like patients like who are not menopausal, there's no value, like there's no value in measuring an endometrial thickness. So the value of an endometrial thickness in someone who is pregnant, who has delivered, and therefore you're seeing products. But otherwise, in a normal gynae examination, we want you to learn how to use the endometrium just to be able to look at your position. But generally, you want to be able to see that in the first phase of the cycle, right, you can see it's homogeneous, and then later on, proliferative says it will be a trilaminar layer, and then towards the end, in the luteal phase, it will be hyperechoic and it will be bright. And it can go as big as 16 millimeters. So I think it's very important that you know that this is physiological, timed with the cycle, you know, of a person. So this is not pathological. So with that now, when someone you want to do an endometrial thickness post-menopausal, so you're gonna go the mid-sagittal plane. You don't want to get an area that has got fluid, and you're going to look at the canal, and then the thickest part you're gonna move from the outer to the in of the canal, and then you're going to take the measurements like we can see them there. And then now there is this phenomenon. I said the obese patients at risk of cancer. So they have got what we call endometrial hyperplasia. So if you look at this, you can actually see some hyperechoic areas right within this endometrium. And then it should make you suspect that like this is actually also very thick. So when the patient has a risk of endometrial cancer, so if you see the endometrium looking like this, you see these lakes, you see these abnormalities, then you will actually realize that there could be hyperplasia, and the hyperplasia tends to be homogeneous, well defined, and there could be some vessels, but very minimal vessels. And then these are the cystic spaces that you see within that. And then sometimes there will be a mass, sometimes there's no mass. But the myometrium of this is actually completely normal. And then fluid is actually uncommon. And then it responds to hormones, right? It may regress. So if you give me progesterone, so that's why we say when we manage abnormal bleeding, we actually give patients depot. And when we give them the depot injections, this thing can actually regress or get smaller, and especially when you've got hyperplasia. So when you take the histology, but it's important to take the histology, and when you take the histology, you will get an endometrial hyperplasia with atypia. So when you have atypia, then there's a risk of a cancer for the patients, and therefore those patients may opt for a hysterectomy. Then with endometrial carcinoma, it tends to be much bigger than 15. And really, there may be areas of necrosis, irregular cysts, and the patients, if you look at this, you actually can see. So it's very important when you see that it does look as nice, you need to put a color Doppler onto this, and then the color Doppler will shine up and you'll see these red legs. And then this will give you a reason to suspect that this is not just benign. So I'm saying this is all things that you can do in the district hospital setting, as long as practice the transvaginal ultrasounds, and don't rely on abdominal ultrasounds. Then you will learn as you go along. So I am almost okay. If I give too much time, you're gonna ask me lots of questions, but I've been rushing. Sorry. So basically, just in a nutshell, all right. Please, whenever the patient has abnormal bleeding, in the younger patients, you want an estrogen. Then for 3 months, I'm trying to recap here. Then I said progesterone, right? You can use progesterone as a second choice. And then with NSAIDs, and we talked about the tranexamic acid. But now we have a problem of I don't know, guys, if you get as irritated as I do with patients who want to go and remove the implanon. If people have implanon, I always ask them, okay, my darling, if you had received depot, which is the injection, and you had side effects, right? You had bleeding, you had bleeding irregularities. Were we going to be able to suck the depot out of your bum? No, we won't. So colleagues, we mustn't give this first thing that, oh, I want to take it out. No, I want to take it out. No, when people have got an implant, we must understand that we can manage. The patients have got an estrogen deficiency, which is being running because of this implant that they have. So I think we need like reassurance by ourselves as clinicians, because after 3 months, normally those symptoms will get better. So what will you do? So initially you want, but people are saying they're struggling with Premarin in their settings, but ideally for 1 to 7 days, we just want to use Premarin only. It really does reduce the days of bleeding. Then if you don't have access to an estrogen composition that is not without progesterone, your next option now is to give estrogen with level. So you can use oral or you can use NODET. So you can use either of the two. But when you started using it in these patients, right, you need to make sure that you're going to use it for a whole month. And when people know that they can go to the red line, which is vitamins, and then they can use it for a second month, and we see mifepristone, because mifepristone has an impact on the endometrium, right? And the vessels distribution in the endometrium, it can be used. But in our setting, most mifepristone, we have it available in the 2OP centers, but it's someone we are struggling with. Tamoxifen, no, we don't use it in government. And then there's some small studies that have used a combination. And now doxycycline does have benefit of an endometrial stabilizer. So if you use 100 milligrams twice a day for about 5 days of doxycycline, so it is actually being recommended. So I want to highlight that. So I think let's try estrogen combined oral contraceptives. You can resort to mifepristone, and then you can resort to the tranexamic acid, and then remember that the doxycycline is also an option, and so that you can use doxycycline for a limited of 5 days, and then they continue the implant with reassurance. And then I just want to make some acknowledgements. So basically the Knowledge Hub, those of you who are know the Knowledge Hub, there is this modules. This is the sexual reproductive health module, which was actually developed by the Knowledge Hub, and it has got a number of modules. So it will have adolescent sexual health, and some of the slides that I've used, I'm acknowledging that they were coming from this module on menstrual health and hygiene. Some are coming from the contraceptives, and you'll see safe abortion, you'll see PMTCT, you'll see subfertility is there, genetics there, disability, then breast, cervical, all the cancers under module 12, breast and cervical cancer. But you have to do that module 1. And then after you've done that module 1 and completed, you can then download any of the other modules after having completed. And then the palliative care. So that's the article that you can use. Sorry about that. Thank you very much. Over to you, Safin.
Thank you very much, Dr. Mandondo. That was quite comprehensive, and we truly appreciate the time that you took to give us that wonderful talk. I will hand over to anyone who has a question to take this opportunity. We have about 15 minutes for that. Or you can put it in the chat if you're not comfortable asking. Okay, maybe let me break the ice. So, Dr. Mandondo, I just want to find out, with the investigations that you showed us, such as estrogen levels, etc., what happens if they are gate kept then at a primary healthcare facility? Are we able to call maybe the DCST team to allay those restrictions?
All right, thank you, Doc. The only thing that the key is still keeping. So if you notice, right, everything is at PHC level, FSH, the LH levels. You look at the ratios between the two. The things that are gate kept will be the karyotype. So the karyotype now can be done. So this is the patient that you may be unsure that you want further management. So if you have a tennis, for example, the patient needs estrogen, like they use oral contraceptives at low doses to stimulate breast production, and you know that their breast and secondary sex characteristics. So now in that setting, you need that karyotype analysis, for example, in this setting, so that you can get your access. So that patient now will need to be referred to the guy. But otherwise, for most of your workup, for most of the workup, it's all things that we can do, right? We can all do at PHC. They are also allowed to use prolactin. They can do prolactin levels, TSH levels, FSH levels. So these are things that should be available. And then once you've done the workup, you can send with the results, and that would really help. And I think the progesterone is also available at the PHC level. So, but yes, if in doubt, you can contact your DCST to assist you, you know. But it works best if you also call the tertiary and tell them. Then the karyotypes, you need to tell the lab, and then you must do them in the morning because they need to be couriered within a day or something. So I think the lab to be aware that you plan to do a karyotype. But you can just check with your local lab if there are courier issues.
Okay, thank you so much for that answer. And my second question, with regards to ultrasound scales, it appears that, in the gynecological landscape, we really need those skills, especially at a primary healthcare setting. Are there any courses that we can do from a PHC level? Not something that's going to be, of course, too, complicated or at a specialist level, but something that is going to be capacitating any clinician who's working in a primary healthcare setting with the skills necessary to make these kinds of diagnoses, like seeing a polyp, for example, on an ultrasound, a vaginal ultrasound, etc. Those kinds of skills. Is it in the pipelines, or is it already available?
All right. Thank you very much. For the people who are closest to Umtata, Dr. Kumbu does take doctors from the district for an enrich in their ultrasound unit. She's a fetal-maternal specialist. But by default, you tend to learn the gyne ultrasound. We run today ultrasound courses here in East London it's just a basic orientation. But I would say that if people want to learn, I think I want to encourage clinical managers to release people just for a day or two. So we normally just run the course, and then I'm not sure about the online course. ISO normally runs online courses, but I'm not sure if you must be registered or a member, because they've got very good material, and I think they run a course with pre-recorded videos. So I can share that link for the ISWalk. I know FPT does it. Ultrasound course is expensive. And if you are specifically interested in gyne ultrasound, people tend not to train on the gyne ultrasound. Most of the courses that are available are for obstetrics. So you can also check with FPD and the course, but specifically for the gyne ultrasound, there is a cost. But I think what we do normally teaches the basics, but it's a short lecture. But I think the main thing is just probe handling, which you must make go and visit a tertiary center and learn. And the more you do gyne ultrasounds and you know how to orientate yourself, you'll be better at doing them.
Thank you so much, Dr. Mandondo. I can see one question on the chat. So for perimenopausal women on tamoxifen for breast cancer treatment with heavy with heavy AUB, can't see, and cleared for endometrial, there's something that's appearing over the comments, so I can't can't make out. Okay, I think it's end cervical cancer. Can they have Mirena inserted? If unavailable, what can be used?
The problem with the breast cancer patients, some of them, breast cancer is not only about it's not only about you can use an IUCD, but with Mirena, you avoid progesterone. So we can go to the medical eligibility well, and you can check breast cancer. Then if you go there, you will find that they will not be giving them both either progesterone. No, they will not give them either progesterone. They tend to avoid both estrogen and progesterone. So we are a bit limited in terms of our options for those patients. We will stick to tranexamic acid and NSAIDs more often. And then for patients with cervical cancer, no, we do not use. If there is a cervical pre-malignant condition, patient has an IUD, it's not a transmesh. You continue doing the LEDS procedures and doing the procedure, with the IUCD inside. To remember, colleagues, sometimes you want just an IUCD for contraception, but let's reserve the Mirena for those ones who are having a bleeding abnormality.
Okay. Thank you so much.
You can use an IUCD, but the question is, do you need the progesterone? Yes, if you do, yes, you can use it.
Thank you for clarifying that question, Dr. Mandondo. I am not seeing any question in the chats. Colleagues, please feel free to unmute yourself and ask, or put your question in the chat. Otherwise, if we don't have any questions, I take it that everything was clear and that you are feeling confident in managing patients with abnormal uterine bleeding in a primary healthcare setting. And we will put up the poll. I did send the link earlier. Please do make sure that you fill it out so that you can get your CPD points. But if you haven't had an opportunity to join Rudasa, then unfortunately you won't be able to get the CPD points. The CPD points are specifically for members, and the membership fee is 0 cents. So please take advantage of this opportunity. I've just shared the link. Okay, let me try to. I'm sharing it again. Okay. Yeah. So that is the link that you should fill for your CPD points. And thank you so very much, Dr. Mandondo, for taking time off your busy schedule to give us this amazing talk. I do believe that it will definitely impact patients' lives in a positive manner. We wish you all the best with all your endeavors, and thank you to everybody that has joined. We will have another webinar that will be announced on our WhatsApp groups and even on social media. Please do look out for that. It will be an interesting one. Thank you very much.
All right, thank you very much for the challenge, because I haven't been giving a lot of gynae talks. So I thank those people who shared information and slides and other information to prepare the talk at very short notice. And yeah, and I just want to encourage those people working Amathole. When you see me, you must say, come this side, show me how to do a transvaginal ultrasound. And I think we can all do the practice, but start somewhere. Google, use the videos, use YouTube, and I know that you're going to really familiarize yourself with it. All our scans have got transvaginal probes. It's just a question of us as the clinicians trying to use them. That's why I included those slides. So thank you for really having me.
Thank you, Dr. Mandondo. I am seeing Zine Nzepo has just said she has raised her hand. Unfortunately, it's not appearing on my side. Please feel free to unmute yourself, Zine, and ask your question.
Okay, thanks, Chair Lady. Dr. Mandondo, I've just got one quick question about the adolescent girls that are coming to us with what they label it as a menorrhagia, but on history you've got a feel that is not really menorrhagia per se, it's more of a normal regular cycle. If it happens to be the case, do we give them anything, the 15-year-olds to 17-year-olds who are pregnant, who are not pregnant, the pregnancy test is negative, but then we see that they come every time they're on periods. They seem to think it's kind of a prolonged or heavy periods, but on history, it's not really suggestive to be prolonged and the patient is not really symptomatic with anemia or anything. Is it just for counseling for those patients, or is there anything extra that we can do for them?
All right, thanks a lot, Zene. I think for these patients, we said that these young ones, we must explain. Periods, if you have to wake up at night, that's heavy. If you have to wake up at night to change pads, is that 80 mils, 24-day cycle, up to 38-day cycle, 34-day cycle. So they must understand that it's not abnormal, to have periods within. So we need just to teach them that their cycle can be within 28 days, or it can be, between 24 and 34 days. Then the second thing is that their period, they must understand the frequency is up to 8 days, and this is all ranges of normal. However, with young ones, things that are an issue, especially those 15-year-olds, normally weight, it's weight, it's actually stress, it's academic stress, it's all those other factors. So you need to actually first counsel and find out if there's any changes in weight and all of those things. And then, but normally it's sport, like the new sport, and weight changes will tend to contribute to that. And start light. If they are keen to start a combined oral contraceptive, you can start like with something light, but the take-home message for them is non-steroidals. Just stick with non-steroidals, and let them go. Tell them to go and get Nurofen over the counter at the chemist. Then it will reduce the flow and it will reduce the days, and then stick to that if they are not keen. But if you still think they are repeatedly presenting themselves, then I think there's a point to start a combined oral contraceptive, something low dose like trifazil or not yet. But initially, I think it's just the counseling. And also their perception of this weight gain is completely different. Some of them is psychological. They are not, they are having secondary sex characteristics and their body changes. And that's what they are not accepting. And so the stretch marks and all of these things. So that's why they're presenting, but they will not say that's what is worrying them. So I think this menstrual history and all that is really the thing that's worrying them. And yeah, also talk about the cost of pads. Some of them will think, yo, I'm using a whole packet so many days, you tell them 6 rand, can go to spa, they are just as good, they're subsidized, those pads. Nothing wrong with them, buy them there, So those are the things that when it comes to the adolescent, but definitely if it's persistent, then you have to look at the issues of the thyroid. Just don't miss the thyroid abnormalities. Look for examine them properly, and then you can always do a TSH on them.
All right, Dr. Msode, thanks so much.
Okay, we can't. I can't see the chat. Asafika, anyone else has a burning question? Colleagues, I'm available on the other end of the phone, but let us try to do some basic workup of patients before we send every little fibroid to Frey and make patients transfer, And please ask your clinical manager for the PPLs, postmenopausal patients. And please remember, colleagues, if someone is bleeding heavy, you can use a double strength of Depo. So if they're bleeding heavy, these postmenopausal patients, and even if you suspect cancer or they have cancer, you use 2 injections of Depo, you double the strength, and you'll find a lot of them will actually improve and regress. And then, yeah, once you've excluded pathology, you can put the Mirena. These Mirenas are expiring in your doorsteps without you guys using them. So please.
Thank you so much, Dr. Mandondo, for that talk. I think that concludes our webinar for this evening. We will see you again next time in the next 2 weeks. Thank you so much, Dr. Mandondo. Have a great evening, everyone. Goodbye.
Goodbye. Thank you.